Professor Hughes and I worked together over at OU. Were you there at the time?
I don't know which one.
She had a couple of chocolate labs. They were called like Weasel and Van Diesel or something.
Oh, Liesel and Gretel.
Yeah. So they were, energetic dogs. So one night she goes home, it's like, Gucci, Gucci, Gucci. She comes in the next day and they cut her nose. And they have a plastic surgeon to sew her nose
I
back.
had 15 stitches up in my
Yeah, that's why she looked like that.
Wow. That hurt me.
All right, so we're going to talk about the neck today. You're going to start off with the cadaver still prone to reflect the skin off the posterior aspect of the neck. Then you'll need to rotate the cadaver into a supine position to do the anterior part. If you've already flipped your cadaver for whatever reason, you can just start with the anterior. It doesn't matter. You have to take all the skin off, at least the inferior part of the mandible here. And I'll go over that in just a second. Anatomists, they like to parcel things into artificial groups and boundaries and stuff. They've done so with the neck. They've created all of these triangles. And if you look at the posterior aspect, there's a posterior triangle that's bounded by the trapezius, the superior border of the trapezius, the clavicle, and the posterior aspect of the sternocleidomastoid muscle. Sternocleidomastoid muscle you're going to see very early on today in lab. We're going to mention it here. Is named for its position. It has a sternal head that you see here, a cleido meaning clavicle head, clavicular head, and then it attaches to the mastoid. Good news is a lot of the muscles that we're going to talk about today, they're named from where they originate and insert, so not a lot to memorize. Another one that you're going to see is the omohyoid. The omo means shoulder. So this goofy muscle here actually originates from the scapula back here, crosses the floor of the neck, and has an attachment, a tendinous attachment, really to the fascia here of the neck and to the clavicle, and that changes the direction. So it has two bellies, a muscle belly, you know what I mean about belly? So two muscle bellies connected by a tendon. You have a posterior belly of the digastric and an anterior belly of the digastric. Oh, excuse me, omohyoid. Yeah, digastric is coming next. So the omohyoid originates from the scapula and ends on the hyoid bone. And it changes its direction, as you see here, because of that tendon. All right, so going back to the triangles, we've got the posterior triangle here, and we'll go over the contents of the posterior triangle later on. The anterior triangle is bounded by the mandible, the inferior margin of the mandible, the anterior margin of the sternocleidomastoid, and the midline of the neck. The midline of the neck. That's the anterior triangle. And it's further subdivided into 14 billion little triangles that I don't care about. It's either anterior triangle or posterior triangle. That's how we're going to parcel things today. And when you're studying this and trying to remember, memorize the structure of the neck, you ought to know whether or not it's posterior triangle or anterior triangle. Hint, hint. Okay. There's another muscle I mentioned just a second ago called the digastric. We're going to see this here in a little bit in other slides, but the digastric is a muscle. Here's the hyoid bone right here. The digastric originates really kind of at the base of the skull, sort of. We're going to stay there, base of the skull. Comes down with a tendinous insertion here, or it's not really an insertion. It's a sling. And so the tendon of the digastric goes under that sling and then moves forward. The anterior belly of it attaches onto the mandible. So it too changes its direction because of that mid-muscle attachment. So the omohyoid and the digastric both have two bellies. Okay? All right. Now before we get into the structures of the neck, we need to talk about the fascia planes that are in the neck. These are very important for several reasons. Surgically, they're very important. The other thing that's very important about them is that infection or tumor or anything really, if it gets in between two planes, tissue planes, it can traverse through those planes to reach other areas of the body. For example, and we'll illustrate this later on, you can have strep throat that can wind up penetrating through one of the tissue planes and taking that bacteria all the way into the chest cavity. All the way into the chest cavity. That pain, the chest pain as a result of an oropharyngeal infection is called Ludwig's, Ludwig', Ludwig's angina. It's chest pain, angina, but it's due to an infection of the oral cavity. And that's not good to have bacteria crawling around inside your chest. So, yes, ma'am.
Is it only due to streptococcal infections?
I'm sorry?
Is it only due to streptococcal infections, or do other organisms?
No, it could be other organisms, but that's the most common by far. Okay, so we have the skin in this greenish color right here, greenish yellow color is the subcutaneous layer, the superficial fascia. This green layer right here is the deep fascia surrounding the muscle mass. That's called the enveloping fascia. You see the top of the deep cervical fascia. It's just like any other deep fascia that you've seen in the back. It's the tough, thin, shiny coat overlying the muscles. There are a couple of other fascial groups here in the neck, though. If you take the enveloping fascia here, you see that contains the trapezius muscle, overlies the trapezius muscle. But the deep muscles of the back here, the splenius, semispinalis, and those things, there's another fascial layer inside of there that's actually called the prevertebral fascia. Prevertebral fascia. It goes in front of the cervical vertebra and then wraps all those posterior neck muscles into one big group. It's kind of a misnomer. It's prevertebral because, yes, it goes in front of the vertebra, but it also swings around the back and gets all of these deep muscles of the back. I don't know why they named it prevertebral as an exclusion. There's also a fascial plane that covers the trachea, the esophagus, and down here at the bottom, the thyroid gland. This is called the Bucco pharyngeal fascia, or the pretracheal fascia. There's the trachea right there, pretracheal or buccopharyngeal. Now this fascial plane, if you take your hand and grab your trachea and your viscera right here, that fascia is around it. You can follow it up, the fascia goes all the way up to attach to the base of the skull around the oropharynx. So that's a natural barrier from the stuff that you eat. Okay? And finally, there's a fascial plane. Yes?
Will you say the structures contained in that again?
Yeah. So if you put your finger right there, that's the trachea.
Okay.
That you're touching. So that's the trachea. Behind it is the esophagus. And the other labeled structure that's right there is the thyroid gland. Okay?
What are you trying to say?
No, I'm just mentioning. It's all up there. Okay, so anyway. April, right? Okay, I'm trying to remember, I'm trying to learn names. Bear with me. A friend of one of our preceptors, actually, she graduated back in the 90s. She said, you know, my entire goal for going to PA school was to graduate without you knowing my name. So, anyway. Taylor, right? Okay. Caitlin, right? Sydney. All right, good. All right, there's a fascia around the neuromuscular bundle that's on either side of the trachea here. That's called the carotid sheath. It's a very important structure, the carotid sheath. It surrounds three structures that aren't labeled. No, they are labeled. The internal jugular vein, the vagus nerve, which is cranial nerve 10, and the common carotid. Any questions about that?
Can you repeat that?
Are the green dots?
Oh, the green, yeah, the yellow dot right there is the vagus. The green dots are lymphatics.
Okay.
Over on this side, for some reason, they didn't put a yellow dot. You have a vagus on each side. So I don't know why they screwed the pooch on that one. Okay. One other thing I want to show you on this picture before we move on is this muscle right here. There's a muscle in the subcutaneous tissue that attaches to the skin, the dermis of the neck, and arises from the mandible here. That muscle is called the platysma. When you do like this, you do like that, that's the platysma you're contracting. What is, when you do that, how would you describe that? How would you describe that?
Grimace?
It's a grimace, which is a facial expression. Which is a facial expression. What nerve innervates all muscles of facial expression?
Seven.
The facial nerve. That makes sense. Okay? So when we get in here and you learn that all these other muscles are innervated by other nerves, remember that platysma is innervated by cranial nerve 7 is a muscle of facial expression. The other thing you need to keep in mind is that when you remove the skin here, notice that the platysma is in the subcutaneous tissue. If you remove the skin and you're looking at the sternocleidomastoid, which is here, your platysma is in the other hand. You're holding the platysma. It's big. It's thicker than the posterior serratus, superior and inferior, but not much more. And it's in the subcutaneous tissue. If you're looking at the enveloping fascia, it's gone. Okay. Don't take a lot of time looking for it, but if it's there, it's kind of interesting to see. The surface anatomy of the neck. If you take your hands here, and you can feel your hyoid bone right up underneath your mandible. You can feel, if you run it laterally, the hyoid bone is a U-shaped structure. You can follow your back and you can kind of squeeze the hyoid bone a little bit. It's a little pliable, right? Don't break it, don't break it. That's one of the things in forensics is they look for choking, usually involves a fracture of the hyoid bone. Now, if you run your finger inferior to the hyoid bone, you're going to feel that there's sort of a mushy thing that seems kind of tight. That is the thyrohyoid membrane. The thyrohyoid membrane. And then if you follow it down a little more, you're going to run into the laryngeal cartridge, the thyroid cartridge right here with its laryngeal prominence. That's your Adam's apple. Above that is a notch you can feel. And if you can't feel it on yourself, and women, this is not, this is a testosterone, the development of this tissue is exaggerated by the presence of testosterone during development. So, especially around puberty. So if you reach over to one of the guys in the room, they have more, these are more prominent structures.
Okay, Paul, come down here.
Yeah, wait till we get to the pelvis and perineum. So. Now, if you follow your finger down, put your finger on the notch here, you follow it down, you'll feel a little gap right there, and then you'll feel another hard cartilage. That's the cricothyroid membrane right there. Cricothyroid membrane, because that inferior piece of cartilage is the cricoid cartilage. And then below that, if you go below that, you feel down here, all that cartilage down here, these are the tracheal rings you're feeling, the tracheal rings. If you're going to do an emergency, it's called emergency cricothyrotomy on somebody that's choking, or somebody with laryngeal edema because of anaphylaxis or something like that, the place where you incise is the cricothyroid membrane. If you're going to put a long-term tracheostomy in somebody for throat cancer or something like that, those long-term surgical approaches go through the tracheal rings, whereas in a restaurant or in an emergency situation, you go through the cricothyroid membrane. Over here on this person right here, you can see the two heads of the sternocleidomastoid, very easy, and the attachment point is back over here on your mastoid process, which is that bony prominence behind your ear. Also, on this person right here, they have a neck that's thin enough. You see these two muscles going up through like that? Those muscles are going to be arising from the sternum and inserting on the hyoid bone. That's called the sternohyoid muscles, there are two of them.
So is the platysma visible then on the lady? That's
No, not really. She's not doing that. You can also see, though, the external jugular vein is right there. That little thing right there, the external jugular vein. We'll talk about that. Okay. All right. So, vessel-wise, let me talk about the arterial supply of the neck. Coming out of the heart is the ascending aorta, and then you have the aortic arch, and then the descending thoracic aorta, which separates it from the abdominal aorta, which is also descending. The first two branches off of the aorta are the coronary arteries, the right and left coronary arteries. They're not depicted here. But then you have the three major arteries that arise from the crest of the arch. Supplying the right side of the head, neck, and upper extremity is the brachiocephalic artery, or trunk. Brachiocephalic artery or trunk. That's this thing right here, and it will divide into a right common carotid and a right subclavian artery. On the left side, you have these two, the common carotid and the left subclavian, coming off as independent branches off of the aortic arch. Way towards the end of the year, when we're in pediatrics, I'll go over embryologically why this happens, this asymmetry happens. But suffice it to say now, you have three of the great vessels that come off of the aortic arch. That's the brachiocephalic trunk, or artery, the left common carotid, and the left subclavian. Now, coming off of the subclavian are the vessels that supply the neck. The first one off of there that's not labeled on this picture is the vertebral artery. We'll see that in a subsequent slide. The vertebral artery is going to ascend, obviously, to go to the cranial vault. The next one off of there is a trunk. That's the thyrocervical trunk that has four branches. It has an inferior thyroid. The inferior thyroid artery comes up, and that's that little curvy thing right there, that enters the thyroid gland from the bottom. You also have a superior thyroid that comes off of the external carotid. You see up there? The superior thyroid comes down from the top. And just while I'm at it, off of the superior thyroid, there's this artery right here called the superior laryngeal artery. That artery pierces the thyrohyoid membrane to supply the larynx.
Can you say that again?
Uh-huh. So the thyroid gland receives its arterial supply from both directions, a superior thyroid and an inferior thyroid. The inferior thyroid comes off of the thyrocervical trunk, it's one of the branches. The superior thyroid comes off the external carotid. Now, coming off of the superior thyroid, though, is another little artery. It's called the superior laryngeal that pierces the Thyrohyoid membrane you see there to supply the inside of the larynx, the vocal folds and that sort of thing. Okay, everybody cool on that? One of the other, and so you want to find that inferior laryngeal, inferior thyroid artery today. Now there is a small branch, it's called the ascending cervical. Don't spend time looking for that. It supplies the deep muscles and deep structures of the neck. It comes off of there and goes straight up deep in the neck. Very little clinical relevance. The inferior thyroid obviously has a lot of clinical relevance because of the number of thyroidectomies that you're going to be involved with. Now, the other two branches are the top one is the transverse cervical. Where do we know the transverse cervical? That's what supplies these things in the back, these muscles in the back. So the route that it takes, let me just kind of show you on this skinny neck person here. So the reason actually she has this open skirt, blouse thing on. You have one on too. Kristen.
Yeah.
Okay, so if you look at where this is right here, that thyrocervical trunk is going to be coming off right about, if you look at the clavicle, it's going to be right about there, right? So if I put my finger there, I can feel the pulse over a subclavian artery right there, okay? So it's going to be right in here. So that, you want to put you got a pen, come with a pen. So that thyrocervical trunk is going to come up right up there.
So can we do the pose for us during this section?
Yeah. Okay, so here it is right here. That's going to be your thyrocervical trunk. And so here's her trapezius right here, right? Because the transverse cervical artery, the superficial transverse cervical, supplies the trapezius, right? So it's going to come off of here and enter underneath her trapezius right there. So that's the top one. Now the bottom one is the suprascapular. It comes off a little lower, and it's going to come swing around here and go to supply these muscles of the scapula. So right there, when y'all get to that, you can see her, the thyrocervical trunk on her. Thank you, Bethany. Any questions about that?
So, you said that
These arteries are smaller than a pencil. They're smaller than the thickness of a pencil. About half the size of the thickness of a pencil. This artery right here, going downward, you won't see that today because it's kind of deep in there. That's the internal thoracic that's going to be going inside the chest wall.
For the thyrocervical trunk, there's like a bunch of them. Can you point them out again? Which one's which?
This is the suprascapular.
Okay,
That's the transverse cervical.
okay,
That's the inferior thyroid.
okay.
That's not coming off of this. That's
Yeah, it's just going behind.
behind it.
Okay,
And that's the ascending cervical.
thank
Okay.
you.
Oh, man.
and you said the transverse cervical artery innervates the trapum. What else did you say about it?
The transverse cervical
Not
artery,
innervate, sorry.
it supplies, it divides, once it gets back here, it divides into a superficial branch and a deep branch. The superficial branch supplies the trapezius. The deep branch supplies the rhomboids. Now, in this illustration here, they've kind of done something that really doesn't happen. You see that little artery right there, the one in back? That's a dorsal scapular artery. So if you don't have a deep transverse off of the thyrocervical trunk, but a separate branch coming from the subclavian, that's what you call it. But we don't need to worry about that today. Okay? Now there's 4 branches off of the thyrocervical trunk. Now, if you look at this slide right here, you can see them again. You can see them again. Here's our brachiocephalic artery, common carotid, subclavian. There's the vertebral going up through the foramen transverse area. Here's our thyrocervical trunk with the inferior thyroid, ascending cervical, transverse, and suprascapular. Okay? Very nice. One other thing about the vertebral here is you see that if you count down from the top, 1, 2, 3, 4, 5, 6. You see the vertebral, that's the first foramen transverse area it goes through. There's C7 right there. It has a hole in it, but the vertebral artery does not go through that hole. Yes?
If we're going to go through the parts of the trunk on a test, we'll use this illustration instead of the other for, like, say, the inferior thyroid, ascending cervical, and suprascapular and transverse cervical.
I'm not sure of the question.
You'll
see, if I tag an artery, like if I've got the thyrocervical trunk and I tag an artery, you will see where it's going.
Okay.
I'll dissect it out so you'll see, if you follow it, you can follow it all the way up to the inferior part of the thyroid.
Okay.
I'm not going to just have 4 things sticking off a little nubbin and say, what is that? Mainly because I just don't want to hear your bitching about it. That's why I'll dissect it on out. On the venous side, you have actually a right and left brachiocephalic vein. On the arterial side, there's one brachiocephalic artery. On the venous side, there's a right and left brachiocephalic vein. The right brachiocephalic vein is depicted here, where you've got the subclavian. And if you see behind the sternocleidomastoid, you can see the internal jugular. You see it sort of superimposed behind there. On the external surface of the sternocleidomastoid is the external jugular. External jugular, internal jugular. So, remember that the enveloping fascia is on the outside of the sternocleidomastoid. If you take the skin off where you're looking at enveloping fascia, not only is the platysma in your other hand, so is the external jugular. It's very superficial. It's in the cutaneous tissue, subcutaneous tissue. There's an anterior jugular vein, and then there's some communicating veins. All of these things drain the external jugular essentially drains the face. The internal jugular drains the inside of the cranial ball. Now it's very easy to see the external jugular. If I can spin you around here, and kind of lay it back a little bit, move all of this here. If I just take, do you see where it is right there? It's right there on the clavicle, going right behind the clavicle. If I just take my finger, here's her clavicle right here, and I put my finger right there on her clavicle, you can see her external jugular light up right there. You see that? I mean, it's big as Dallas. Okay? So the other day when you saw that port that was in the EJ, if she's in cardiac arrest and we cannot find a cubital vein here, then if you're up here bagging her, you know, with a bag, breathing her, and they can't find a vein, just simply stick your finger right there, get that EJ to pop up, and it's bigger when you're lying down. Get that EJ to pop up and just take that, it's called an angiocath, just stick it right in there, and now you've got easy IV access. EJs are easy to get. And there's not really that much around them, and it's superficial, so you're not going to hurt anything. Okay? Now, y'all go get a room. Y'all go get a room. You two, go get a room. I don't have that in my class. All right. Any other questions? Now, you can say, what is that stupid little muscle right there?
Good thing he
Right,
was
that's the
the other.
posterior belly of the hyoid. Okay. I don't know who thought it was a great idea to hook your hyoid bone to your scapula. Why? Why would you do that? If I do like that, you know, it doesn't even make sense. Or if you chew and your hyoid bone's going up and down, you're so, I don't know why, it doesn't even make sense. Here's another picture of the veins. You've got the external jugular, the internal jugular is here, and then they're usually communicating veins that will cross there. Now, one thing I want to point out on this illustration here is that you see, remember I told you you would do an emergency cric right here? If you, here's the thyroid gland, I'll go over this in a little bit more detail later on, and there's the thyroid cartilage, there's the cricothyroid membrane right there. If I'm going to stick a needle or a ballpoint pen or something in there so you can breathe, the direction of this cut in the skin should be vertical. Should be vertical. If you go across to make that cut, you're going to get huge bleeders from these anterior jugulars. So go vertical. Go vertical.
Oh, that's where they like, where people like shove the empty pins in the other
They're like
one's
straws.
throats.
Yeah, yeah.
Oh, those are.
A straw usually won't work because it's pretty tight, but something hard plastic will go through there. You can actually take, there's a thing, you can actually take a needle and stick it in there, put the needle on a 3 cc syringe, take the hub off of an endotracheal tube, put it on top of that, and then you can actually bag through that. It's a, you know, kind of a MacGyver type thing that you'll learn later on. Okay, any other questions about that? Here's the platysma to show you how superficial it is. Now this thing right here is, these are your ventral primary rami, essentially from C1 on down to T1. And it describes, it illustrates two different plexi. A plexi is a mishmash of a network of nerves. So there's a cervical plexus up here that runs from C1 to C4. And then this down here is the brachial plexus from C5 to T1. The brachial plexus supplies the upper extremity. The cervical plexus supplies the neck. Now, you're going to dissect all of these nerves before we get to the end of the upper extremity. Today, though, for this first test, we don't have to worry about the brachial plexus. We're just going to focus on the cervical plexus. Now, the cervical plexus is interesting because it's divided into a sensory component and a motor component. The sensory component is in the posterior triangle. The motor component is in the anterior triangle. So it's very easy to keep things separate here. If you look at this illustration here, these main nerves right here, supraclavicular, transverse cervical, greater auricular, and lesser occipital, they are sensory, therefore they're in the posterior triangle.
Can you say that one more time?
Yeah, it's these four nerves right here. Supraclavicular, transverse cervical, greater auricular, and lesser occipital. They're sensory, they're going to be in the posterior triangle. Now in the front, in the anterior triangle, there's a nerve that runs right here under the mandible. That's cranial nerve 12. That's the hypoglossal nerve. Right there in yellow, the hypoglossal nerve, that's cranial nerve 12. The hypoglossal nerve provides the motor innervation to almost all of the muscles that control your tongue. And we'll go over those when we get to the oral cavity. All of them, but really one. are controlled by the hypoglossal nerve. And it's right here under your mandible. The angle of your mandible, right here. You can find it easily. Now, here's the thing. C1 comes out and runs with that hypoglossal nerve. C1 comes out and runs with that hypoglossal nerve. And right here at the angle of the mandible, it branches off. The hypoglossal nerve will turn and go up in and over the hyoid bone and into the back of your oral cavity because it's going to go to your tongue muscles, all right? That branch of C1 continues straight down as what's called the superior root of the ansa cervicalis. The superior root of the ansa cervicalis is made up of C1.
What's it do?
I'm sorry?
What does it do?
Give me about 37 seconds. C2 and C3 join together and form the inferior root of the ansa cervicalis. Ansa means loop. The superior and inferior root loops meet right there, and then you see where, Ryan, you see where those little nubbins are off of there?
Yeah.
Those are going to muscles of the neck. This is the motor innervation to the muscles of the neck. Many of them. I'll go over them here in just a second. So this is the motor part of the cervical plexus, and that's the sensory part.
So it's superior root and lateral root.
Superior and inferior root.
Oh, inferior.
I'll tell you what, let's make a deal with each other. Nah, I can't really say that. Yeah, let's make a deal with you. If you just call it the ansa cervicalis, we'll be happy.
So
You don't need to be able to identify it as superior and inferior root, but it's easy to do because you can follow this up. If you want to find the hypoglossal nerve, this ansa cervicalis, when you are looking at when you cut the sternocleidomastoid and reflect it up and down, and you remove the carotid sheath, which is easy to do, the ansa is sitting right there. It's laying right on top of the carotid, the common carotid and the internal jugular. You take one end of it, you follow it north, and if you run into this big nerve, that's the hypoglossal nerve. And that's the superior root. What was the question? Yes, ma'am.
So C1, 2, and 3 combine to form,
The ansa.
okay. 1, 2, 3.
C4 gives rise to the phrenic nerve. It's not part of the ansa. Okay? Now, here's the nerves. Here are the sensory nerves. Yes, ma'am.
Is the...
Bethany. Yes.
Is the phrenic nerve part of the cervical plexus, or?
Yes. She asked, was the phrenic nerve part of the cervical plexus? Yes.
Motor
And sensory.
and sensory.
Why sensory? Why sensory? You know it's motor because you can drive your diaphragm.
Because all visceral.
Not
Efferents
visceral.
have an afferent?
Not visceral. Why are there, okay, there's somatic efferents, right? It's a voluntary. There are somatic afferents. How do you know there's somatic afferents? Because you know how contracted or not contracted your diaphragm is, right? But going back to what you were saying, visceral efferents and visceral afferents, are they in there?
Yes.
Yes. Why are they in there?
Blood vessels.
They're blood vessels in the diaphragm. Are they sympathetic visceral efferents or parasympathetic?
Both.
No. Sympathetic. There are no parasympathetics to muscles, to skeletal muscles. There are no parasympathetics to skeletal muscles. The diaphragm is a voluntary muscle. It's a skeletal muscle. Okay? All right, so here we have the posterior triangle, and there are the four nerves that we're gonna find today. Now, I don't want you to spend hours looking for these nerves. They're cutaneous nerves, right? So if you've removed a lot of the skin and the stuff, then they're gonna be gone. But if you go to so here's the sternocleidomastoid right here, where my pointer is. At the midpoint of the sternocleidomastoid, on the posterior aspect, that's where all these nerves come out as one group. So if you want to find these nerves, go to the midpoint of the sternocleidomastoid, right there in the posterior triangle. They're all there. The greater auricular goes to supply the skin in front of the ear. The lesser occipital behind the ear. The transverse cervical wraps around the front of your neck to supply the front of your neck here. And the supraclaviculars, there are three different groupings of them. There's an anterior, intermediate, and posterior. They come over here and supply the top of your shoulder here. All right?
Which ones do that?
Supraclavicular, clavicle. Yes, ma'am.
So you said if we're looking for it will come out straight out of this?
I'll show you in another slide. I have no idea what this thing right here represents. I have no idea. All right, here's the ANSA. You can see it illustrated well here. C1, superior root. C2 and 3, inferior root. Now this is what the ANSA innervates. It innervates the omohyoid, both bellies, the inferior and the superior. And it innervates two of the muscles of the neck, the sternohyoid and the sternothyroid. Remember early on, and I showed you, we were talking about the surface features of the neck, the sternohyoid, you can see it on that woman, that's innervated by the ANSA. It sits right on top of the carotid, and it's superficial to the carotid and internal jugular. Very easy to find. You're going to be digging around in there, and you're going to say, where is this ANSA, where is this ANSA? And it's going to be right in front of you the whole time. Now, these things, the ANSA itself is probably thinner than twine. It's thicker than sewing thread, but thinner than twine. Here's everybody's favorite topic, the autonomic nervous system. Now, remember, we'll do this and then we'll take a break. T1 to L2 in the lateral horn. What do you find there?
Why?
The white ventral
Sympathetic, preganglionics. The sympathetic, all sympathetic, preganglionic. All, this is the maxim. All, you know what a maxim is?
No.
There ain't no exceptions. This is the law. All sympathetic preganglionic cell bodies are located in the lateral horn, or IML, between T1 and L2. That's the law.
Can you say that one more time?
Awesome.
All sympathetic preganglionic cell bodies are located in the IML, the lateral horn, between T1 and L2. Here's the IML right there. That preganglionic comes out, it's going to enter the chain. Remember, we've got gray and white rami here between T1 and L2, right? In the neck, well, in between T1 and L2, each segment has a ganglia. But when you get up into the cervical region, even though you have 7 cervical vertebrae and 8 cervical nerves, you only have 3 ganglia. There's a superior, middle, and inferior cervical sympathetic chain ganglia. Superior, middle, and inferior right there. And sometimes you don't even have that. Sometimes you just have a superior and inferior. You're not going to find the superior. It's way up here underneath the skull. You can find the sympathetic chain in the neck very easily today. It's right up under the carotid. It's not part of the carotid sheath. It's outside the carotid. If you go between the carotid and the trachea, just spread them apart, there's the sympathetic chain. So that's preganglionic. So we've got all these sympathetics in the head and neck, right? We know we got the fight or flight. We've got to have something to dilate the pupils. The way this happens is those preganglionics will ascend and synapse in either the inferior, the middle, or the superior cervical sympathetic chain ganglia. They'll synapse on the postganglionic cell body. Postganglionic sympathetic cell bodies are located in one of two places, the chain ganglia or the preaortic ganglia. You got to have a synapse in one of those two places. The postganglionics come out of there and they'll just hitch a ride on the blood vessels to get to the target. Now, if I'm going to get to the eye, if I'm going to get sympathetics to the eye, the way that happens is the sort of a general rule is that the cervical sympathetic chain ganglia sends postganglionics inside the head, like to the dura and other structures. The middle and inferior chain ganglia send their postganglionics along the external carotid to go to the face, like to the sweat glands, blood vessels of the face and stuff like that. Okay. So here's how you get the sympathetics to the dilator pupillae. The preganglionic is at T1. It comes out, enters the white ramus, does not synapse, goes up to the superior cervical chain ganglion where it will synapse right there. That postganglionic comes off of there, goes up through the internal jugular, enters the cranial vault. One of the first branches off of the internal carotid. One of the first branches off of the internal carotid is the ophthalmic artery that goes to the eyeball, supplies the retina and the eye. It enters, that postganglionic enters the eyeball from behind, from inside the cranial vault. And that's how you get it there. Okay? Now, everybody understand that? When you have a headache, a headache is caused by vasodilation of mostly meningeal arteries, not the arteries of the brain. They have no sensation. It's the arteries of the meninges. Drugs used to treat migraine, the way you treat it is you constrict the blood vessels. That reduces the headache. So if you're fighting and flighting and you're running, you want to dilate the vessels inside your head, right? Because you got to be thinking about how you're going to climb that tree. Well, that my wife called me a silverback gorilla today. Anyway, so if you're running away from a silverback gorilla and you got to get away from them, that's sympathetic. So that's why you can see, okay, yeah, they're dilating the vessels of the meninges, the dura in particular. Okay? If you destroy the sympathetics right here, like the inferior chain ganglion, that can happen with trauma, like a knife wound, a bullet wound. It can happen with cancer of the lungs that invades right here. I'll explain why this happens when we get to the chest, but it can invade right here. If you destroy the sympathetics right here in the neck, it produces a syndrome called Horner's syndrome. Horner's syndrome is characterized by the loss of sympathetic tone to the face. It has three characteristics. One is that it has ptosis of the upper eyelid. It's there's sympathetic tone that helps keep your eyelid up. That's not the thing that opens your eyelid like you're opening your eye. It does provide some tone to your eyelid. So if you lose that sympathetic, the eyelid will droop. Drooping eyelid is called ptosis. P-T-O-S-I-S. Up there somewhere. Ptosis of the eyelid. The second thing it causes is constriction of the pupil. Why does it cause constriction of the pupil? Yeah, it's parasympathetics and sympathetic. If you remove the sympathetics, all you have are parasympathetic. It's unequal, and they will be constricted. Because that's what the parasympathetics do. And finally, you'll have a dry face. Why do you have a dry face? Right, you have no sweat gland, innervation of sweat glands in your face. So those are the three hallmarks of, and I guarantee you that's a board exam question. Probably not only an anatomy exam question, that's a board exam question. Okay? Why don't you go pee potty, and then we'll come back to the second stuff.